Bene, buonasera a tutti. A nome dell'Istituto Cardiocentro vi do il benvenuto a questo secondo pomeriggio del Cardiocentro del 2026. Saluto i partecipanti in sala, numerosi, e sono sicuro che saranno numerosi anche i partecipanti collegati. Ne vediamo 55 finora, ma aumenteranno sicuramente. È un tema molto interessante e penso molto importante nella nostra pratica quotidiana, quella cioè degli score cardiologici e biomarkers, se e quando e come usarli. Penso che tutti siamo cresciuti negli ultimi 10 anni usando sempre più biomarkers, usando dei risk scores che ci vengono raccomandati. Il problema è di capire quando e come usarli e soprattutto come interpretarli. E penso che stasera abbiamo davvero l'opportunità di avere due top leader in questo campo. I would like now to switch to English, just because one of our main speaker come from Basel, and he will have his presentation in English. So I have the pleasure to introduce you, Christian Müller. We are really honored and privileged to have you here in Lugano. I think you probably all know him. He's a very famous researcher. Professor Christian Müller is a director of the Cardiovascular Research Institute in Basel, and probably you know him because of the several publications in the area of biomarkers, mainly troponin. He's the troponin man, known worldwide. And the second speaker, which will be introduced by Mattia Rigo, the co-chair, is the new head of cardiology, also a top leader in cardiovascular research. And I think you have your own risk score, the precise score. So then the floor is yours, Christian. Thank you very much for having accepted the invitation, and thank you very much for giving bringing your knowledge in terms of new information. Thank you very much.
So dear Giovanni, dear Mattia, dear Marco, dear colleagues, it's my great pleasure and honor to contribute to your important educational program. So when Giovanni asked me to come and contribute, of course, this was a great honor for me. But then he told me that he wanted to have this educational program like a controversy, so pro and con, and said, okay, I think that's a wonderful thing. So controversy is good to highlight the topic, and of course, because Giovanni is such a nice person, I agreed to the invitation. I think none of us ever had rejected the invitation of such a nice person. But then the next thing that he told me is that the debate that he wants to have would be a debate with Marco. And of course, then my attitude changed completely, because, I mean, how can I dare to debate the head of the institute on his home ground? I mean, that's ridiculous. You can never win this debate. I mean, it's obvious. He's the head of the institute. He's playing on home ground. So if Basel comes to play Lugano on home ground, I think that's no chance for me. I think it's 1-0 clearly for Marco. And then I realized, of course, many of you would prefer, of course, me to speak in Italian. Of course, he is Italian by native, his mother tongue, and I need to speak in English. So I think no chance. I think 2-0 for Marco. I think it's I have really no chance to win. And of course, you all know Marco. I mean, he's such a charming, nice person. Oder? It's clear it's 3-0. But then I read careful Giovanni's email, and then he said the debate that Marco wants to have is a debate of what provides more value to our clinical care, whether scores or biomarkers. And then I realized, scores or biomarker? Nobody cares about scores. Nobody uses scores. So I think that's easy now. I think I really are now on equal ground, and I hope that I will be able within the next 20 minutes to highlight to you clearly that biomarkers are much more useful than the fancy scores that he might come up with. I mean, they are nice for some papers, but honestly, who of us really would like to use these scores? So the topic is I will try to highlight to you which biomarkers are helpful and provide some suggestions on how to use them. Again, biomarkers are so attractive because they are biological signals that provide insights into pathophysiology of the body. So they are really quantifying pathophysiological processes. Now, to translate that, I mean, as you know, Marco is an interventional cardiologist, so this likely is not the wording that he would use. So he likes to stick in catheters in patients. So I try to come up to explain to him what is a biomarker. So some people come up to biomarker is a liquid biopsy. So it's just a blood test that is as good as if you would provide a biopsy specimen from an organ. I'd like to, of course, acknowledge that the research that I've been able to do in this topic the last 25 years has been mainly supported by public organizations, but also I'd like to acknowledge the fantastic support of my research team. I have a wonderful group of research fellows that helped to do all the work that to some extent I will share with you within the next minutes. So I'd like to start and highlight the utility of the biomarkers by starting always with a case. I'd like to ask, because I realized that, of course, many in the room work in the hospital setting, but I've been told by Giovanni that many in the audience also work in private practice or possibly even as GP. And I think for the use of biomarkers, it's also important to be aware where we are in order to make sure that we use these tests appropriately. And biomarkers in cardiology, it's a very easy topic because there are only two biomarkers, I think, that you will have to use or have to be familiar with. It's NT-proBNP or troponin. So let's start with a case. So this is an 84-year-old gentleman. He's an Hale pensioner. He's fine. He has a long history of high blood pressure that was well treated with combination drugs. He had permanent atrial fibrillation that was detected by chance in the preparation for an elective surgery and undergoing, of course, having oral anticoagulation. He had some chronic venous insufficiency and some minor leg edema for years in the context of his chronic venous insufficiency. He comes to you for his yearly checkup. And of course, you start the conversation and you ask him how he feels, and he reassures you he's fine. Of course, he's 84. He's not as active as he was in the past. So he used to garden, but this had become a bit too exhausting to him, so he had largely stopped gardening. But he's walking around in his house, climbing stairs, perhaps some small shortness of breath if he's doing more than 2 flights of stairs, but he's 84, so he is perfectly okay with that. Then you record the vital signs. Blood pressure is 125 to 80, pulse is 75, irregular. You know he has a permanent atrial fibrillation. And then, of course, he's in your office, and you need to decide what to do. So you think first one option is to do nothing, or because he tells you he's fine, or it's very difficult to improve the quality of life of patients who report that they are fine. Or you think, because of course this is an interventional cardiology center, and Marco is here, and the patient has not had coronary angiography, so of course would be timely to finally proceed with coronary angiography. Or you think some basic stuff like hemoglobin or NT-proBNP could help, and to just slightly to increase the pressure on you. This is my father. So who's in option of one? In favor of option one, he's fine, doing nothing. Who thinks this could be coronary artery disease, or that there are some symptoms, and you want to make sure that you detect coronary artery disease? Or who thinks the simple basic blood test would do a good job? So thank you. So for the audience online, 100%, including Marco, think that this is something where biomarkers can help and affect. Of course, the ECG showed what you would expect, atrial fibrillation. And the biomarker, quite surprisingly to some, but perhaps not surprising to others, he had an NT-proBNP of 1,000. So beyond doubt, he has heart failure, which can be diagnosed due to his exercise intolerance. And of course, this already allows you to initiate heart failure therapy. Now, irrespective of ejection fraction, we have medication that provides value to all of these patients: small dose loop diuretic, SGLT2 inhibitor, and an MRA. And then, of course, he needs an echo to see what phenotype he has. And as you would expect, like the setting with long-standing atrial fibrillation and arterial hypertension, this is HFpEF, of course, mild increased left atrium, preserved ejection fraction. And of course, that's the therapy that now we have available for these patients. So in fact, this was 4 years ago, and he is fine, and the condition is completely stable. And I think, of course, that the benefit what we can achieve with this intervention is to avoid hospitalization for acute heart failure. And I think that's the benefit of these drugs. They not necessarily might prolong life. We're not sure about that, but they for sure improve quality of life and avoid hospitalization. At least the last 4.5 years has been achieved with them. So why do we need the biomarker? Because, of course, we start with symptoms and signs for heart failure, but the symptoms like shortness of breath, fatigue, weakness, or coughing, weight gain, they are all fine, but they're completely unspecific. And they develop very gradually. So people adjust to them, like my father. He would never have complained to you that he has shortness of breath. Patients simply avoid all activities that would cause shortness of breath. So you have to be persistent to just identify this exercise limitation. And then the problem with the physical signs for heart failure, the standard neck veins, edema, rales, they are great if they are here, but they have a very low sensitivity. So only 50% of patients with heart failure do have these signs. So therefore, you need the help of a biomarker. That's the scheme that is recommended. So you have to have a high awareness in elderly patients, particularly with hypertension, with atrial fibrillation. And then you diagnose with your clinical assessment and the natriuretic peptide heart failure. And then, of course, the work up needs to include an echo to identify which phenotype is it. Do we have a HFpEF like in my father, or is it a problem with the valves or the reduced ejection fraction? So why is the natriuretic peptide so helpful? Because it's a quantitative marker of hemodynamic stress and heart failure. It's released from the heart, from the left and right ventricle, in response to an increase in intracardiac pressure or volume. So everything that causes a problem to the heart will increase the pressure or volume and result in a secretion of the natriuretic peptide system. So it's a hormone that is a counteracting heart failure. And therefore, it's perfect for us for diagnosis, because it detects and summarizes the presence and extent of left ventricular systolic dysfunction, left ventricular diastolic dysfunction, valvular dysfunction, and right ventricular dysfunction. This also highlights to you that it's completely useless to identify the underlying cause of heart failure. Because anything that results in heart failure will result in an increase in BNP or NT-proBNP. So it always needs to be accompanied, if elevated, by cardiac imaging. That's the scheme suggested by the ESC, again, for the outpatient setting. If you have a patient like my father, suspected of heart failure with some symptoms or high-risk features, if the NT-proBNP is below 125, then you can be reassured that heart failure is not present. But if it's elevated, it likely is. So the cutoff to use, I think, in the guideline is not a smart one, because 125 is way too low. So it's a so mild elevation, you cannot be sure what is the cause. So you have to use an appropriate rule-in cutoff. And for the outpatient setting, usually 300 gives a good positive predictive value and specificity. If you try to be even smarter, you can further adjust for age, for sex, renal failure, obesity, or AFib. But about 300 is a good estimate. If you're in an outpatient setting, you have a stable patient, and if the NT-proBNP is higher than 300, heart failure is present and should trigger workup, including an echo, initiation of therapy, because the therapy exactly has been shown to be effective for these patients. So the inclusion criteria in all of the HFpEF studies for the SGLT2 inhibitors was just an NT-proBNP of 300 or more. So 300 is a good number to keep in your mind, please. Of course, then the echo needs to be done to fulfill the second criteria, mandatory for the heart failure definition, so some structural or functional structural abnormality. So these, again, are the cutoffs to rule out heart failure in the outpatient setting less than 125 and to rule in with 300 or more. Class 1 recommendation consistently in ESC or AHA, ACC guidelines. I'm very interested to see how many of the scores that Marco will come up with do have a class 1 recommendation consistently by the ESC, AHA, and ACC guidelines. So it might be a short presentation of only those. Let's see. So now, of course, this is the outpatient setting, elective patients. Many who's working in the emergency department, so who's working, seeing patients with acute shortness of breath in the emergency department. So those of you who are, you need different cutoffs. So that because in the acute setting, filling pressures will be much higher, and therefore you need other cutoffs. And again, to make things simple, 300 again is useful, but here it's for the rule out. In a patient with acute shortness of breath in the emergency department, NT-proBNP below 300 strongly argues against acute heart failure being the reason of shortness of breath. And for the rule-in, again, the higher the concentration, depending on the age, the higher the likelihood for acute heart failure. Most acute heart failure patients are older than 75 years of age, who need concentration of 900 or 1,800 to have a high positive predictive value. And this is a class 1 recommendation because we have evidence from randomized controlled trials that have shown that using the biomarker in addition to all our additional tools provides improved patient outcome. And we had the pleasure to do the first study a long time ago, the Basel study, in which we were able to show the benefit of BNP testing in patients presenting with acute shortness of breath through the ED, published in the England Journal of Medicine, again documenting a reduction in the time to the initiation of adequate therapy, a reduction in time to discharge, and a reduction in treatment cost by applying the biomarker in addition to all other workup that is performed. Again, I'm interested to see how many scores Marco will share with you have been evaluated in a randomized controlled trial and have been shown to improve both patient outcomes and reduced cost. So this was done. LURSNET, initial blood draw, all patients with shortness of breath. Recently, we have learned we have one condition to take into consideration to make even better use of biomarkers, particularly NT-proBNP, and it's obesity. because obesity results in lower NT-proBNP cutoffs. That is a major issue, because if we do not know this, then we will miss patients with heart failure, with mild heart failure, if they are obese. So this is in patients presenting with acute shortness of breath. In red are those that have adjudicated acute heart failure, and in black those who have other causes of shortness of breath. And this is applying the current ESC endorsed cutoff levels, so they work reasonably well. Most of the red ones with acute heart failure are in the rule-in zone, but many of the red ones that have acute heart failure are in the gray zone, and even one is in the rule-out zone. So one person in this scheme represents 2% of the overall population. So therefore, acknowledging that obesity results in lower NT-proBNP cutoff, the cutoffs needs to be lowered. And again, if you lower the cutoff, you have a better classification, much more of patients that are obese and have acute heart failure identified, and fewer patients in the observed zone. So please remember, if you have an obese patient in front of you, you need to use lower cutoffs than those recommended for patients with normal body weight. Troponin. I will be very quick on a troponin, because I think you have a lot of experience using it. So again, I was told many of the people following online might be working in clinic. So this is a patient who presents to a working clinic. He had a chest pain episode, 6 out of 10, experienced as pressure. There was no radiation, no sweating, never had symptoms at exercise before. So then after about 3 hours, he was convinced by his wife to present, and he's completely asymptomatic. So now he's in your office. He's an ex-smoker, but he stopped smoking. He has a very high blood pressure. The pulse is 80. The pulse oximetry is normal. And then, of course, the first thing you do is to do an ECG. So I'd like you to comment on the ECG in these patients. Again, chest pain episode, 6 out of 10, lasting 30 minutes, perceived as pressure. Now he's completely asymptomatic. Does someone want to comment on the ECG? Unauffällig. I fully agree. So it's also the clinical team felt this is a normal ECG. And then, of course, the next thing that you need to do is a troponin. And as this was a walk-in clinic, so they were happy to have a point-of-care troponin assay available. All these troponin assays, they have different normal ranges. So this troponin was reported to be normal and less than 40. That's what the device said. Who has worked with this, just by chance, with this troponin assay before? Until very recently, it was the most commonly used troponin point-of-care assay in Switzerland. So until 2 or 3 years ago, this troponin assay had a market share regarding point-of-care of about 80% in Switzerland. So it's a very commonly used troponin assay. So of course, so normal troponin, normal ECG, high blood pressure, patient is asymptomatic. The team felt okay. It's not clearly what the chest pain was. Perhaps it was related to the high blood pressure. Perhaps it's coronary disease, but for sure troponin is normal or nothing bad. Antihypertensive therapy was started, and follow up at cardiology for some exercise testing. You would agree that this is reasonable, or you think this is completely nonsense what they did? Who thinks this is reasonable? Please raise your hand. Okay, so for the audience, only the vast majority here think it's reasonable. I think so, same. So patient was instructed that, of course, if something bad would occur, he would have to represent. And in fact, something really bad occurred, because 4 days later, he had another chest pain episode, this time much more severe, 10 out of 10, and this time with radiation to the left arm. This was the ECG that was recorded. So who wants to comment on the ECG? Still unauffällig. So now this is something that, of course, Marco loves to see. This is clear ST segment elevation myocardial infarction. We love this in cardiology, because these are the entity that we have such excellent treatment available. The patient was, of course, rushed to the cath lab. The right coronary artery was reopened, and he had a good course. But of course, we have to go back. I mean, the patient presented for his first episode. What happened? So fortunately, this patient was enrolled in a study where blood was drawn at several time points, and it was frozen so that we could measure it with other assays. So as you see, he had several blood draws with this assay, and all of them were normal. If you would have done the blood test with a good troponin assay, you would have detected. So this is the assay I think that also you use in Lugano. So it's a good assay. Marco uses it. So it has an upper reference limit of 14. Everything until 14 is normal. So it's borderline for a young man at presentation, but already at 1 hour it's clearly elevated and continues to rise. So what was clearly something that was missed by the point of care assay. So normal with a bad point of care assay can still be clearly elevated with a good assay. So the point that I'd like to make is we have a major pitfall with many point of care assays that are still on the market. About 70% of point of care assays are poor and have poor sensitivity. So they miss N-STEMIs, and not only few, they miss about 1/4. 25 of all N-STEMIs are missed by the poor quality point of care assays. That's the scheme. So the poor quality point of care assays, they are good if it's elevated, but they cannot really make sure that it's really normal. Therefore, the BAG has insisted that only those point of care assays are now reimbursed that have good quality, and a lot of change has occurred. But be reassured, there are still some poor point of care assays around, and it's important for you as cardiology to educate GPs and all other people that they need to have a good point of care assay if they want to use it to rule out myocardial infarction. Fortunately now, several good point of care assays are available, so there's no longer any excuse to use a poor device. Everybody has to use one of these that are BAG conform and that have good ability to rule out myocardial infarction. What you learn, what everybody has learned using these assays is that troponin is a molecule that is unique to the heart, and it's released. So for example, you use troponin T, it's green. So everything green is troponin T. Myocardial infarction, large amount of troponin T, but it's important that all of us have troponin in our blood. Those that are young and healthy, like Marco, have only 1 or 2 of the green molecules in the blood. Those that are older have more due to chronic disease and chronic myocardial injury. So it's a quantitative marker. And again, it's not a pregnancy test with positive, negative. You really have the concentration to consider. One last case to see you how easy it has made life for us in the ED. 61-year-old gentleman, chest pain. It started 4 hours ago, again perceived as pressure. The duration was again half an hour, intensity 4 out of 10. There was some radiation to the left arm, and then the pain disappeared. The patient had some risk factors, smoking and hypercholesterolemia. This was the ECG. May I ask you to, so you're now in the emergency department setting. You have a patient with this history, this ECG. Would someone like to comment on the ECG?
Normal ECG.
Normal again. Thank you. All the clinical team fully agreed with that. Troponin concentration, high sensitive troponin was 4 nanograms per liter. So really, really low. And again, what would you do? You think you still need to monitor the patient, have a second measurement after 1 hour? Or you argue, oh, this still could be coronary disease because there was radiation to the left arm, and you would send the patient to Marco? Or you think this you can already now decide for outpatient management? So may I argue who's in favor of option 1, do a second troponin? Thank you. Who thinks this is good for Marco to do something? Nobody? Who thinks you can decide already now for outpatient management? Excellent. It's always good to do a measurement also after 1 hour. It's not really necessary in this patient because the troponin concentration is so low. So therefore, this is the scheme suggested by the European Society of Cardiology, highlighting, of course, we want to decide as early as possible. And if the troponin concentration is really, really, really low, And the cutoffs, of course, have been derived and validated, and they are assay specific. So for your test, if the concentration is below 5, like it was in this person, and the chest pain onset was 3 hours or more, which also was the case, then you can discharge or rule out MI already with a single measurement. You were absolutely right. For all other patients, you need the second measurement just to be sure that there is no rise. But here you would have been able to do this with a single measurement. Then, of course, you know, the higher the concentration, the higher the likelihood for MI. In a chest pain setting, 52 is the ruling number at presentation, or more than 5 within 1 hour. So these are the concentrations. The patient had outpatient follow-up, stress testing, no ischemia, and is fine. Dear Giovanni, dear Mattia, dear Marco, I'd like to summarize. I hope you agree that biomarkers are much more fun and much more useful than scores. You have to apply them in the setting that you're working with. The concept is identical, but the cutoffs are different, whether you work in the ED setting or whether you work in the GP setting. And again, all biomarkers that you need to consider are NT-proBNP and troponin. Thank you very much for your attention.
Thank you very much, Christian, for your nice and brilliant presentation, and also very didactic. I guess there will be questions either in floor or from remote. I just did see that there are 90 participants, so it's a highly attended meeting. Congratulations to the speakers and to, I think, take the opportunity, young cardiologist, to address question to Christian. I personally have 2 questions. One concerning the NT-proBNP, because we all know how to use, when to use, but sometimes the question is how frequently we need to use the NT-proBNP. It's not just a diagnostic test, it's also a prognostic test, extremely important. We can use to differentiate between diastolic, HPF and HREF, but how frequently should we repeat in patient with just symptomatic heart failure?
Yeah, very good point. And of course, I'm also interested in hearing Giorgio's and Mattia's view on this. Personally, in my practice, I do it at every time point I see the patient in my clinic, because at every time point, I'm in a diagnostic setting. I have a patient, and patients do have some symptoms. And the point is, we need to identify, are the symptoms related to heart failure or not? And therefore, it's such a simple and wonderful test to show me the condition, the status of heart failure, how well controlled heart failure is. So if the patient has well-controlled heart failure, NT-proBNP has declined and is rather low, and the patient has some symptoms, then I'm absolutely sure that the symptoms are not related to heart failure. They have to be due to something else. Or I have a patient, some patients, they do not complain. They just say they are fine. But then I realize the NT-proBNP is sky high, so then I realize, but are you sure you're fine? What happens? And then patients come up with the true story. So I think if you have a heart failure population, like you need an ECG at every time point you see a patient with heart failure, like you need a potassium and a creatinine at every time point you see a patient with heart failure, I think it's mandatory, for me at least, to have NT-proBNP to make sure I don't miss something. I don't need an echo at every time point, not at all. I think having NT-proBNP helps to identify those settings in which an additional workup is necessary or everything is fine and we can just go on.
Thank you very much. Then the second more provocative question. Let's say patient, 88 years old man with severe aortic stenosis and just, I would say, area 0.8, gradient, mean gradient 36. But it's very difficult to assess the functional class. The patient suffers from all the problems, and the NT-proBNP is 250. Is, in your opinion, an indication to proceed with TAVI or to wait, or in just say differently, is the NT-proBNP indicated and useful in patients with aortic stenosis or other just valvular problems?
Very good point. I think in this setting, it provides some value, but it's a very small one, at least in my practice. So that this patient clearly has severe aortic stenosis. And also there's, as you say, it's sometimes quite difficult to assess whether there are symptoms or not. And so for me, I think this is really a joint decision-making with the patient, whether to proceed to the workup for TAVI or not. Because there's good evidence now that even possible asymptomatic severe aortic stenosis derives benefits. So from a medical perspective, I think in this border zone, it's more about really patients' preferences. I agree that anti-proBNP helps a bit. The higher, the more likely it really is symptomatic. But I think here, I think it's more the preference of the patient, whether they want an intervention at this point in time or not.
Thank you very much, Mattia. Or just take the opportunity. It's a unique opportunity. He's the king of the biomarkers. Okay, I see now that you started realizing.
Waking up. No, I'm joking. Thank you so much, Christian. So nice to have you here and to revamp in a way the discussion that we had many times in the setting of the ESC guidelines. So actually, I'm not planning to debate you formally, but in your presentation, which as always was very brilliant, you in a way made my day and my point, because you presented anti-proBNP and you said that if you want your words, if you want to be smarter, you have to integrate this single data point with age, sex, then you went on discussing obesity. So you are creating already a score. You're not using a biomarker, but you're integrating the biomarker into a multivariable modeling, which helps you to integrate and assess that single biomarker. So how can you be relying on a single information without integrating all the others? That's what the score does for you. Why you want to make your life so complicated by just looking at the number and then remembering all the cutoff point? Oh, the patient, what is the BMI of the patient? The score can do that for you already.
So I think it's the question of what we consider a score. I fully agree with the point that the biomarker or the concentration needs to be considered in the context of age, sex, and some other factors for some of the biomarkers. But the question is whether we have to do this within a rigid score or with one of the rigid scores that are available. I hate most of them. Therefore, I think as a physician, I feel much more comfortable having the biomarker, the information without being bound to a rigid score. But I fully agree, it does not mean to ignore other information and not to use it in the context of a specific setting. So I think that is absolutely mandatory.
Thank you. Brilliant presentation. You showed us the brilliant case highlighting the main drawbacks of point of care troponin testing, which are increasingly used by GP. But what do you think will be the future for point of care testing?
So point of care is a evolving field. Now there are, and we have in Switzerland, at least 3 options available at point of care that are as good as the large laboratory platform in your hospital, in our hospital. But point of care is more expensive. So therefore, I think it will only really provide added value in settings that are distinct to a central laboratory. The central laboratory cannot be bet by efficacy, quality standards, and everything. So if you have a reasonably well-run central laboratory and a good short distances, I think the central laboratory option likely will be the best one for most settings. However, there are many settings where there's no central laboratory around, including GPs, including clinics, including some walk-in clinics, but also possibly including the ambulance. So I think there is, with the good new devices, we will see, I think, a lot of studies trying to improve patient flow in patient safety by applying good troponin assays distant from the hospital.
Well, no domanda. Christian, thank you very much for the nice presentation. Maybe can you share with us a little bit more of your experience, huge experience in with the natriuretic peptides in obese phenotype? Because I mean, this is really an issue. Obesity is a pandemic, and FPEF is as well a pandemic. Echo in these patients is not always easy, and so we really trust natriuretic peptides, but as you told us, maybe they do not help us every time. So how do you deal?
I didn't say that.
No, I mean, to be careful. So
absolutely. So I think that the point is, if you have a patient that is obese, particularly those that are severely obese with a body mass index of 35 or more, you have to halve the cutoff concentration, reduce by 50%. We do not fully understand the mechanism. Likely, it seems to be associated with the pericardial and epicardial adipose tissue that seems to be the cause for this, which means I try to suggest that 300 or higher indicates in the chronic setting heart failure. If you have a patient with a body mass index of 35 or more, this goes down to 150. So you get the same positive predictive value, the same in a severe obesity. You just have to lower the cutoffs. It's such an important confounder.
But regardless of the weight, is it just obese and then reduction 50%?
Again, I try to make
or is it proportional?
It is proportional, but I think above the body mass index of 35, it's fair to say reduced by half.
Okay.
Thank you for your brilliant presentation. I have two small questions. Just a deeper dive on the specificity of the test with respect to troponin. So we are not used to missing out any acute coronary syndrome anymore. We rule out ACS pretty specifically, but I mean, how many false positive do we have? Do we have statistics about that? How do you deal with the specificity of the test? And the second question is about combining those two markers, like in the setting of heart failure. If you combine troponin and NT-proBNP, do you have some kind of ratio? Do we have data about this that can help us discriminate a heart failure based on coronary artery disease as opposed to a heart failure which has another cause?
Yeah, two excellent questions. So the first one, specificity of the troponin test, or of high sensitivity troponin. So the test itself is specific, but the question is, what cutoff do you use, sort of for what clinical decision? Any increase in troponin indicates cardiomyocyte injury. But you're absolutely right, with the high sensitivity tests, we have nearly abolished the sensitivity problem of the older tests. We have no major issue with missing patients with myocardial infarction. I cannot recall a patient in which we had identified that we had missed myocardial infarction in the last months or years. But we have a huge problem, like you mentioned, identifying the small infarcts or differentiating them from the chronic causes of cardiomyocyte injury, particularly heart failure or any other chronic cardiac disease. And for this differentiation, the change is so important, right? Because most of the chronic disorders, they would just have nearly no change, or the troponin remains the same. Whereas acute myocardial infarction needs to demonstrate the clear rise. And therefore, the 1 hour algorithm or 2 algorithm is so powerful, because here you see the change within 1 or 2 hours, and you can discriminate between an acute event, like acute myocardial infarction, from the chronic one. But still, in this box of the acute events, you still have all the patients with an acute myocarditis, all the patients with Takotsubo syndrome, and therefore, of course, it's never specific enough for MI on its own. You need to then proceed to coronary angiography or any other imaging to make the differential diagnosis. the combination sometimes helps, and I think it often helps in patients in whom also heart failure is part of the game to see what is the dominant one, or because patients with acute heart failure, they have some elevation in troponin, but usually only mildly, 25, 30, and it remains the same. But of course, NT-proBNP much, much higher. So I think as soon as some shortness of breath is part of the game, NT-proBNP is very helpful as an additional component to identify what is really the main problem.
I'd like to ask your opinion on the emerging role of MR-ProANP and its potential implication in the cardiovascular field beyond the neurology.
Yeah. So MR-ProADM is ADM, oder? Adrenomedolin. ANP. Oh, sorry. So ANP is the natriuretic peptide that is predominantly secreted from the atria. And it seems to really have a near perfect correlation with BNP or NT-proBNP. The only field where it's currently gaining traction is in some endocrinology disorders, but also in the risk stratification of patients with stroke. So there is data that the higher the NT-proBNP, the more likely it's a cardioembolic stroke. You have similar data for NT-proBNP or BNP. But that's the only setting where, at least from my perspective, you have enough evidence or strong evidence that and some sites are really using it. Like you can do the same job with NT-proBNP, but there are some very good studies also with ProANP. However, I think they tell the same story.
What is the historical background? Because, I mean, the neurologists tackle with ANP and the cardiologists BNP.
Okay, it has very little to do with science. It's a different company that has the patent for MR-ProANP, and they invested in the studies on stroke. And so there's good evidence regarding ProANP, and little has been invested with NT-proBNP, and therefore it's highly appropriate to use MR-ProANP. But again, there are some studies indicating you could do the same with NT-proBNP. It's just what you are used and where what biomarker with the study has been performed. But the correlation between the two is excellent.
So thanks again. Beautiful discussion. Unfortunately, for the sake of time, but I had a very last short, quick question. For cardio-oncological patient, troponin T or troponin E? It's a debate.
Yeah, so very good question. And in fact, cardio-oncology is evolving, fascinating, but at this point in time, it's quite challenging. So in fact, I think in many of these patients, we need both. So there's good evidence. Many of the prognostic studies have all done with cardiac troponin T. However, cardiac troponin T has one important Achilles heel, and it's chronic skeletal muscle injury. And particularly the new oncology drug with the checkpoint inhibitors, they not only cause myocarditis, but they also cause myositis. And in this setting, we often have patients that have an elevated cardiac troponin T, and then it's mandatory to have, in addition, cardiac troponin I measured to verify whether it's really the heart or whether it's predominantly the skeletal muscle. So I think you're perfectly fine, as you have it here, and we have it in Basel, to have cardiac troponin T as the working horse. But for some settings, exactly, particularly cardio-oncology patients, we have to have a backup of cardiac troponin I to identify these false positive elevations. They result from re-expression of the fetal cardiac troponin T in skeletal muscle. It takes some time, or this injury in the skeletal muscle, and then the cardiac isoform is re-expressed, and therefore it gives if you wish, from a cardiac perspective, false positive elevation of T, but you can easily identify it by measuring I.
Excellent answer. Thank you very much. And now we are ready to move on. Ho il piacere adesso di invitare il dottor Fabio Cataneo per una presentazione di un caso clinico. Come sapete si alternano presentazioni e casi clinici, 2 presentazioni e un caso clinico a metà, che verrà, penso che lo farà in italiano. Sì.
Sì. I switch to Italian, sorry. Buonasera a tutti. Presento questa sera un caso clinico. Si tratta di un paziente che siamo abituati a vedere qui in cardiologia quasi tutti i giorni, e vorrei seguire un po' la storia di questo paziente durante la sua ospedalizzazione per vedere un po' come applicare i diversi score o i diversi biomarker sin dal momento del suo arrivo all'interno del pronto soccorso. Si tratta di un paziente di 72 anni con alcuni fattori di rischio, è un fumatore attivo, iperteso, con una storia familiare di cardiopatia ischemica, una BPCO Gold 2 e un'insufficienza renale di grado lieve. Arriva in pronto soccorso con un dolore toracico associato a dispnea, insorto da circa 30-40 minuti, e qui possiamo vedere l'elettrocardiogramma che viene eseguito non appena il paziente mette piede all'interno del pronto soccorso, che come possiamo vedere non mostra un sopraslivellamento del tratto ST. Viene quindi iniziato quello che è il percorso diagnostico che il professor Müller ci ha appena descritto, con la misurazione dei diversi biomarker. In particolare possiamo vedere una troponina alla sua prima misurazione lievemente elevata, la cui interpretazione può essere però in realtà mascherata da un BNP severamente incrementato. E allora ecco che ci aiuta molto nel chiarire se la prima troponina dipenda da una sindrome coronarica acuta piuttosto che possa essere riferita esclusivamente a un quadro di scompenso cardiaco, il successivo decorso, dove vediamo un incremento significativo, accanto poi all'applicazione di uno degli score che noi abbiamo a disposizione, l'HARD score, che mostra come questo paziente in realtà presenti un rischio di eventi cardiovascolari maggiori nei 30 giorni successivi estremamente elevato. A questo anche la clinica ci viene in aiuto. Vediamo che l'ecocardiogramma è consistente con delle alterazioni della cinesi nel territorio tributario del riva, e questo ci orienta verso una diagnosi di infarto miocardico complicato da uno scompenso cardiocircolatorio acuto. E andando avanti cominciamo a dover affrontare una serie di scelte. Innanzitutto, quando rivascolarizzare il nostro paziente, con quale timing. È un paziente da rivascolarizzare nelle 2 ore successive, abbiamo 24 ore di tempo per poterlo rivascolarizzare. In questo caso ci può aiutare uno score, il Grace score. Vediamo che il suo Grace è elevato, ma non così elevato da giustificare una presa a carico entro le 2 ore dal suo arrivo, entro 2 ore diciamo dalla diagnosi, e quindi abbiamo una 24 ore di tempo per poter migliorare il quadro di compenso cardiocircolatorio di questo paziente, per poi procedere alla coronarografia. Coronarografia che dimostra una malattia coronarica, interessante il tronco comune, vediamo una stenosi critica del tronco comune, una malattia non significativa della coronaria destra, e qui affrontiamo un'altra domanda: come vogliamo rivascolarizzare questo paziente? Sarà un paziente da rivascolarizzare per via chirurgica oppure potrà beneficiare di un intervento percutaneo? E qui gli score che possiamo utilizzare sono tanti, non abbiamo un biomarker a disposizione che ci possa guidare nella scelta. Possiamo utilizzare uno score come il Syntax, che prende a considerazione dei fattori esclusivamente anatomici, e allora questo forse suggerirebbe che un bypass potrebbe essere superiore rispetto ad una rivascolarizzazione mediante PCI, ma se integriamo questo score con quelli che poi prendono in considerazione anche la parte clinica, possiamo vedere come la mortalità intraoperatoria di questo paziente non sarebbe trascurabile, attorno al 5%, e come in realtà il risultato di una mortalità a 4 anni di distanza sia inferiore applicando una PCI piuttosto che rivascolarizzando il nostro paziente per via chirurgica. Ed ecco allora che viene sottoposto ad una dilatazione del tronco comune e all'impianto di stent. Abbiamo finito di curare il nostro paziente? In realtà no, abbiamo ancora tante decisioni da prendere. Dobbiamo monitorarlo e dobbiamo decidere quanto a lungo monitorare il nostro paziente, in particolare per vedere l'evoluzione della sua funzione renale. e allora avremo a disposizione questo score che ci permette di predire quello che è il suo rischio di una nefropatia da mezzo di contrasto ed eventualmente la necessità di un trattamento dialitico, score che magari ci potrebbe anche già aiutare in sede di pianificazione di una PCI per quantificare o quantomeno per fare attenzione all'utilizzo del mezzo di contrasto nella minor quantità possibile. Abbiamo anche decisioni più difficili perché dobbiamo scegliere una terapia antiaggregante. La terapia antiaggregante forse è più semplice scegliere quale farmaco utilizzare. Abbiamo sicuramente dei dati certi sul vantaggio degli inibitori forti del P2Y12 rispetto al clopidogrel, ma per quanto a lungo, gli studi nel corso del tempo hanno aperto un'ampia serie di possibilità. E qui abbiamo diversi score, qui ve ne presento uno, quello che noi utilizziamo più comunemente, il Precise DAPT, che ci permette di integrare dei parametri di laboratorio e dei parametri clinici per andare a identificare quello che è il rischio di sanguinamento dei nostri pazienti, con dei dati a supporto di, in questo caso, una durata più breve di una doppia antiaggregazione, dati che in realtà mostrano come questi pazienti con un Precise DAPT elevato abbiano allo tempo stesso anche un rischio di eventi cardiovascolari più basso quando hanno una DAPT di più breve durata. Tante volte i pazienti sono ancora più complessi, possono sviluppare anche una fibrillazione atriale nel corso del ricovero, come questo paziente, e anche qui dovremmo innanzitutto decidere è indicato o non è indicato introdurre la terapia anticoagulante orale. Siamo ormai tutti abituati ad utilizzare il CHADS-VA per scegliere quando introdurre o meno la terapia anticoagulante nei nostri pazienti e volendo avremo anche a disposizione degli score per effettuare un trade-off tra quello che è il rischio di sanguinamento e il rischio trombotico a distanza del nostro paziente. In tutto ciò non dimentichiamo poi del valore prognostico di quello che è il seguire nel corso dei primi giorni del ricovero dell'andamento della troponina, con il picco della troponina che ha un valore prognostico per il nostro paziente, essendo correlato con quella che è l'estensione del danno miocardico. Ed è così che scegliamo di lasciar rientrare a casa dopo 7 giorni il nostro paziente con una triplice terapia antitrombotica di breve durata. Vediamo che abbiamo seguito, diciamo, la strategia di default che oggi viene proposta, 7 giorni di terapia antitrombotica, riducendo però il tempo con cui il nostro paziente assumerà poi l'inibitore del P2Y12. Con questo caso clinico volevo un po' mostrarvi quello che è l'utilità degli score che abbiamo a disposizione in associazione con i biomarker, che però devono essere sempre integrati un po' su quello che è gli aspetti clinici dei nostri pazienti. Vi ringrazio.
Grazie mille per la presentazione del caso. Non so se ci sono domande. Io magari una domanda. Riusciremo a fare medicina senza score? È chiaramente una domanda provocatoria, no? Abbiamo una moltitudine di score che vengono presentati, tra alcuni hanno anche degli overlap, difficile poi districarsi tra tutto questo. E, come vedi, il ruolo dello score, se è più una guida piuttosto che quasi una legge.
Io penso sia una guida che ci possa utilizzare, che noi possiamo utilizzare e ci possa aiutare nei casi complessi. Abbiamo delle decisioni, dobbiamo prendere delle decisioni a volte nel quale non è solo bianco o solo nero, a volte oggettivare la nostra scelta con dei parametri come degli score ci può aiutare nel prendere la decisione che speriamo sia poi quella giusta.
Una domanda provocatoria, una riflessione provocatoria. Si sta andando con l'intelligenza artificiale, col machine learning, verso la creazione di score molto sofisticati. È immaginabile in un futuro che tutto quello che è riassunto sotto forma di 5-6 score e algoritmi si integri in una personalized recommendation for the patient, perché in fondo se si va verso la personalized medicine, questi sono dei tentativi di personalizzare, ma non lo sono realmente.
È possibile, gli studi vanno in questa direzione nel ricercare di sviluppare degli algoritmi sempre più sofisticati che includono un numero di variabili sempre maggiori e che difficilmente noi potremo applicare da soli con la nostra testa o con i nostri calcolatori sul telefono per ciascun paziente. È probabile che questi sistemi di intelligenza artificiale tra qualche anno entreranno a far parte di quello che noi tutti i giorni utilizzeremo e ci aiuteranno a curare i pazienti.
Era un po' in quella direzione che andava la mia osservazione, no? Nel senso che in tutti i processi diagnostici si deve comunque partire da una valutazione, cioè non si può semplicemente aspettarsi il risultato e decidere unicamente sul risultato, no? È importante partire da uno scenario, valutare una probabilità pre-test e poi interpretare il risultato in quel contesto. Altrimenti si rischia di farsi un po' portare alla deriva, ed è un po' il rischio che c'è con questo grande hype, no, dell'intelligenza artificiale. Butto dentro tutto, mi dà un risultato e lo seguo, e che però si può potenzialmente, non sapendo bene come vengono mescolate e elaborate certe variabili, non si sa bene cosa esce e si rischia di trovarsi poi con dei risultati molto sorprendenti e che si discostano molto da quello che è poi il contesto clinico, no?
La selezione su chi e come applicare gli schemi diventerà il passo fondamentale per poterlo poi fare.
Che c'è un po' il rischio di poi prendere per buono solo quello che ci fa comodo, no? C'è un po' il rischio, misuro 14 parametri, seleziono i 4 che sostengono la mia tesi e gli altri 10 che non stanno bene in linea, li scotomizzo e li tiro via, no? Questo è un po' il rischio spesso del fare tanti score, tante misure, anche perché statisticamente 1 su 20 è falsamente positivo dal punto di vista molto statistico.
È giusto, però d'altra parte no, dico, però Mattia, Giovanni, l'alternativa è la clinica o l'esperienza clinica, nel senso, e quindi anche quella naturalmente ha dei limiti, quindi probabilmente è chiaro, forse siamo adesso nella fase tanto degli score della I e probabilmente la via, non so, la via di mezzo naturalmente, però anche la clinica da sola e l'esperienza ha dei limiti.
Hai fatto vedere bene come in uno scenario clinico ci si trovi spesso a dover ponderare il rischio emorragico e quello ischemico. Abbiamo diversi score nel nostro armamentario, il Presis DAPT, che è post-angioplastica per la doppia, antiaggregante, abbiamo l'AS bleed, il CHADVA, che sono per un setting di atrial fibrillation. Mi chiedo, si arriverà mai in futuro a uno score che includa entrambi i rischi e quindi faciliti questo processo decisionale, faciliti, non risolva, oppure è abbastanza utopistico considerando che alcuni fattori di rischio parallelamente aumentano sia un rischio che l'altro, come l'età o banalmente insufficienza renale?
Sappiamo che i pazienti che hanno un alto rischio di sanguinamento spesso sono quelli con un più alto rischio trombotico, e un po' il limite e la difficoltà dello sviluppo di questi score, che il professor Valgimilli poi ci presenterà ancora più in dettaglio, ed è un po' il limite della loro applicazione oggi nel stabilire quale delle due parti prevalga. Tra quelli che vi ho mostrato in realtà c'è un sistema che prova a superare questo e a creare un trade-off tra quello che è il rischio trombotico e il rischio di sanguinamenti, la cui applicabilità deve ancora però essere dimostrata in maniera prospettica e in maniera estremamente più forte rispetto a quello che è a disposizione oggi.
Bene, adesso penso che grazie mille per la presentazione e la discussione. Penso che come annunciato adesso andremo più a fondo nei temi legati agli score. E mio piacere introdurre il maestro di cerimonia e nonché padrone di casa, Marco Valgimigli, neoprimario dell'Istituto Cardiocentro, nonché evidentemente grande esperto di score. Marco, stage is yours.
I will switch into English. Thank you very much, Mattia, Giovanni, Christian, for having this conversation. So I'm not so stupid to debate you. I'm not planning to debate you because I don't think the topic should, in fact, be debated. I will simply take this opportunity to quickly go through some scores which have all been endorsed by the guidelines with some degree of recommendation we can discuss later. And mainly because I will be focusing on those scores which are actionable, and I will clarify what actionable means, because that is a key point when considering the score. We are not statisticians, we are not epidemiologists, but very few considerations on how the score should be interpreted, because I think there is a lot of confusion in that area. When you have a score in front of you, you need to understand what discrimination means and what calibration means, and how these two figures can in fact interact with each other, and how you should gauge the value of this score clinically based on these two figures. So calibration is basically the plot that you see here, is how much what is predicted can be matched in terms of real observation. And if the observation are identical to the prediction, of course, every single observation will be lying on these lines, this bisector, which is dividing the area into identical area. And normally this calibration is done by visual estimation. There is not really a statistical figure for that. That is important because if the score says that your risk of MI is 10% and your risk of MI is 1%, you have a problem. That is a score which can be highly discriminating but very poorly calibrated. Discrimination is how much you can differentiate, thanks to the score, the true positive from the false positive. And this is normally something which is interpreted with the area under the curve, area under of this curve. So the area under this curve here is 50%, that would be 0.5, which basically means a random allocation in these two plots. You don't need the score, you just try to guess, and that is 0.5. Everything which is on top of 0.5 actually tells you that the score is better than the random allocation. You allocate the person to a case or a non-case based on a random distribution. Now, the key point that I would like to discuss before walking through the scores is that I think there is a lot of confusion, even among experts, about how the area under the curve should be interpreted. Now, many would think that the score is completely pointless or useless if the area under the curve is below 0.9 or 0.8. But this is completely not true, because when you think about an area under the curve for a score, you need to understand the differentiation between diagnostic and prognostication. A diagnostic thing is something which is already there in front of you, and you need to detect it. For those scores, of course, the area under the curve should be in excess of 0.9. Otherwise, you are just wasting your time. Like MRI against angiography for detection of obstructive myocardial infarction. If you use a prognostication score, this is a completely different ballgame. You want to foresee something which has not occurred yet. And in this case, it's impossible that the score will have this performance. If you see something with this performance, it's probably not true and not reproducible, which is extremely important. Having said this differentiation, you see that even across the literature, the cutoff for telling you that the score is good or not good, it's very vague. It depends on how you sell it. It depends on what is the standard of care. And basically everything which is in the range from 0.7 upwards, it's something which is considered acceptable or with some potential clinical usefulness. Now, we have already been debating this one, so I'm not going to go there. Perhaps we go to that discussion later. I want to walk you through some scores which, again, have some established clinical utility. So you have these two Swiss citizens in front of you in your outpatient setting, and you need to understand how to handle LDL of this gentleman. or this female citizen. The first is a Swiss male, youngish, current smoker, non-HDL42, systolic blood pressure relatively okay. And the question is, what is the real target of LDL that you should be reaching with this individual patient or citizen? Actually, it's not a patient. By raise of hand, should be A. Who is in favor of A? Who is in favor of B? Who is in favor of C? Educated audience here. And who is in favor of D? Nobody. What about this second case? Swiss female, relatively elderly, not smoking, 4.8 of non-HDL cholesterol, normal pressure. What is the best LLDL target that we should aim for in the outpatient setting? By raise of hand, 1.4, 1.8, 2.6, 3.0. You don't have to bother because there are scores which are telling you. In this case, you were right, or the majority of you were right. In the second case, actually, the majority of you were wrong because you were selecting this 2.6. This is according to guidelines. We should base this decision-making upon these two simple scores, score 2 and score 2 OP, basically in patients who are non-elderly or elderly, respectively. You should integrate non-HDL cholesterol, as seen before, region of provenance, as you see here, sex, age, smoking, and systolic blood pressure. The score should be applied only in patients who never had a cardiovascular event or are diabetic, simply because there is a specific diabetic version of the score. And you see that you have a table of risk based on predicted risk of myocardial infarction or fatal events or stroke. That's what it is. So a fatal or non-fatal cardiovascular event. You can actually identify a intermediate risk in the first gentleman, which gives you in the moderate risk of a range of in between 10 and 20% here. And that would be associated with a 1.8 cutoff point, sorry, 2.6 cutoff point. And the other one is high risk, and that cutoff point would be 1.8. So you don't have to bother to learn this by heart. There are scores which have been developed purposely. You just need to apply them. Now, these scores are relatively well calibrated, and they are decent in terms of area under the curve. And all these external validation have been performed. The area under the curve is in between 0.7 and 0.8 roughly, which is basically telling you that there is some clinical usefulness, and we have seen it here. They are actually probably better than each of us in guessing what the risk of cardiovascular event is. There is a dedicated version to the score in elderly patient, in which the performance of the score is somewhat lower. We can perhaps discuss later why. The score does not tell you only LDL, should globally tell you how aggressive you should be with all cardiovascular risk factors, including systolic and diastolic blood pressure. And there is a version of the score for diabetic patients in whom there are also diabetic specific coverage, which should be integrated. It's impossible. You're going to do the job by doing this in your mind. You need to have a score, and that's why the score has been reproduced. I think the future will be probably be integrating LP small a, because that is a very important risk enhancer and risk factor for the future. For the time being, we don't have that availability, but for sure, our prediction of cardiovascular events will be improved when the specific score will be available. Second score, which we use every day, is a CHA-2DS without finale, because that has been abolished in the last version of the guidelines. There is integration of these very easy factors, basically heart failure. You see here hypertension, age with two dichotomic values, diabetes, prior events, or vascular disease. Sex is not a contributor anymore for reasons that we can discuss later on. And basically, I'm going to skip this one. The guidelines do enforcing the use of CHA-2DS and CHA-2DS score with the class 1 recommendation, as we were telling before, because based upon this score, you should decide whether you should or you should not start or continue anticoagulation in your patient, in fact, irrespective of the concomitant bleeding risk. The guidelines advocate the use of Hasbled, which has an area under the curve more or less like tossing the coin, 0.5. Gray score. The gray score has already been mentioned by Fabio before. I think none of us would routinely calculate the gray score. which is giving you the risk of death or hospital in hospital death or hospital or event at 6 months. It's a combination of age, heart rate, systolic blood pressure, creatinine, heart failure, and of course, also some other cardiac biomarkers such as troponin, ST segment deviation, cardiac arrest at presentation. You say, I don't need to do it. Well, I would tendentially disagree with that. Not because it gives you only prognostic information you may want to know, or perhaps it's not relevant, but because that information would give you, that score would give you the information of the speed with which you need to bring the patient in the hospital, and with which you need to do an intervention in this patient. And I think with that respect, the recent guidelines are completely wrong, and I'm telling you why. This is the TIMAX trial, which was comparing early versus delayed, and the overall study was in fact negative with respect to the capability of early to have an edge on delay. The message here is that you can take your time and bring this patient to the cath lab without any rush, because that will not be translated into a difference in prognostic outcome. But if you stratify it based upon the gray score, you know that there is a huge difference. In those who are low to intermediate, there is actually no difference whatsoever. You can take your time. But in patients in whom the gray score is high, there is a huge difference in the primary endpoint with respect to waiting or not waiting. And in fact, interestingly, Christian, if you do the same exercise with your biomarker, you don't have such a difference. Only by integrating things together, you can increase your capability of doing what Giovanni was alluding to, precision medicine. These patients are not the same as this patient, and you should not be treat them as such. The guidelines, interestingly, went from class 1A recommendation in this patient to a class 2A. So they said, no, it's okay. You should bring them perhaps to the cath lab very early, but respective to the previous version of the guidelines, there is much less tension. It was class 1, now there is a class 2A. Why this? Because the guidelines have forgotten to do precision medicine. They based the change in the recommendation on this meta-analysis, where all the 17 studies randomizing patients to early versus late have not been stratified by the gray score. And if you don't do this, you don't have much difference of early versus delayed. So this is the rationale for saying from class 1 to class 2A. Now, the problem that a few months later, even before the guidelines were published, there has been another meta-analysis based on all-cause mortality, this time stratified based on this score, which nobody wants to use, and there is a difference in mortality in embracing in those patients early versus delayed intervention. So the biomarker cannot do the job here. It's the application of the score which identify which patients should be intervened upon aggressively versus all the others. The SINTA score has already been mentioned. In fact, we never almost routinely use this score even ourselves, and I think that's a mistake. When I was youngish, a PhD student in Rotterdam, unfortunately, many years ago, more than 20, I see here, I was the first one to publish the first validation of the score by basically computing the number of lesions and how complex they are. The score goes from 0 to an infinite number, depending on how many lesions you have to score. And as you saw, the higher the score, the worse is the outcome of the patient, which may or may not be very relevant. But in fact, it's very relevant because in the syntax study, which developed this score based entirely on consensus, they looked on the fact that if the patient has a low SINTA score, or if the SINTA score is intermediate, the patient can be intervened upon with PCI or CABG in a pretty much similar way. The outcome is the same. But if the SINTA score is high, you'd better off offer CABG to patient than PCI, because the outcome is completely different, at least in patients whom the surgical risk is not so high. And this is now actually being confirmed at the 10-year follow-up of the study. Look at this. Left main coronary artery disease, irrespective of the SINTA score, the outcome is pretty much alike. But in patients with 3-vessel disease, there is a worse outcome with the PCI than CABG, entirely driven by patients in whom the SINTA score is high. And that's why we should calculate this score routinely, because that would give you an objective measure in which patient to offer which revascularization modality. It's not my opinion. It's not the opinion of the surgeon. It's the opinion of something which is reproducible. And not only the anatomical complexity, but if you integrate the anatomical complexity into the clinical feature of the patient, what is called the Sinta score 2, you can really tease out the outcome after PCI, after CABG, and being able to tease out which patient should be treated how. And the guidelines, again, with class 1 recommendation, B or A, even 2A, are telling us very clearly which patient should be treated how. We can, of course, forget about this course, but that would be a very nice and objective way to say this patient has been sent to PCI for that reason, this patient has been sent to CBG for that reason. This is one, of course, of the equation. The other one is surgical risk, which will be STS score, Euro score, but that would be a very nice way to inform our every week heart team decision making. And to close with, because we are running at the time, few words on the bleeding risk. Now, we have been seeing the precise DPT. Now we have developed a newer version of the score, which is the precise HBR, because we have integrated the 5 coverage, which we use in the precise DPT, with the all ARC HBR features, which take into account the complexity and the multimorbidity of our patient, perhaps coming from our friend Mattia from the internal medicine department. They may have a low platelet count, a chronic bleeding diathesis, a liver cirrhosis, which the score originally was not accounting for, an active malignancy, recent surgery, chronic use of NSAID or steroids. They have comorbidities which the score originally did not take into account, but also they do matter in bleeding risk prediction. And the score is basically simply an updated version, taking the comorbidity of the patient into account. And the beauty of the score is that basically it gives you a predicted risk of bleeding at 1 year time frame, which is basically also informing a short-term bleeding risk, a very long-term bleeding risk, more than 1 year. You have cutoff point to understand whether the patient is high bleeding risk or very high bleeding risk, which is something is sometimes discussed in the guideline, it's never defined before. And why is the bleeding risk so important? A colleague of ours was asking, what about the ischemic risk versus the bleeding risk? Well, because the bleeding risk takes an edge on the ischemic risk. If the patient is at high bleeding risk, irrespective of the ischemic risk, does not take advantage of antithrombotic medication, intensified and prolonging antithrombotic medication. So the priority should come from the bleeding risk. If the bleeding risk is low, then the ischemic risk is relevant. But if bleeding risk is high, you don't need to calculate the ischemic risk. And that's why 2 different bleeding risk scores and ischemic risk scores are much more relevant than integrating one, because the integrated one would lose performance in both ways, ischemic and bleeding, and would not serve the purpose of identifying which patients should be treated how. Very quickly, to understand you why a single biomarker or a single observation can never do the job compared to a score. So many would say that the elderly patient is high bleeding risk by definition. That's what the ARC-HBR consortium, which I belong to, said. If a patient is 75, that consortium would identify the patient at high bleeding risk by definition. This is absolutely not true. Look at the distribution of the score. You may have a very elderly patient who is very healthy, renal function is perfect, everything is perfect, and this patient, despite very advanced age, is not truly high bleeding risk. This is precision medicine, not just guessing a coin. And the same would be for oral anticoagulation. The academic ARC consortium says if you are taking OC, you are high bleeding risk by definition. Well, in the majority of cases, it's probably true, but you do have some patients in whom this is not the case. And this is extremely important. I'm not telling you that these patients should not take oral anticoagulation, but at least you can identify which risk would prevail. Look at the HBR ARC elements. The consortium says by consensus that if one of these elements is fulfilled, the patient is high bleeding risk. This is not true. There are patients whom they do have one element, but they truly do not have a predicted high bleeding risk. And that's why a multivariable modeling can obviate, of course, to the need of to the use of only one biomarker, and that's why you need to score to integrate all these variables. Your mind will never be able to do so, and this score will be automatically given in our warehouse system. So it's not a matter that you don't want to calculate it; you just need to basically integrate them in your everyday clinical practice. To close with, I think today the WISE comments are coming from ChatGPT, and this is what ChatGPT tells us about the scores, which I completely agree with. You probably don't need to calculate them routinely, but especially for the young cardiologists or the one who are getting trained into a system, the fact that you are forced at the beginning to use them, it's also a way of training which variable is important for what. I don't calculate Synta score every time, but I can easily tell you, because I've been doing for many years, where a 33 patient different from a 22. So I have that in my mind. But if you never done it, calculating this score 10 times will be extremely useful to inform objectively the discussion and to teach you how you should treat your patient. Thank you very much for your attention.
Excellent, Marco, as expected. Can you come back to the last slide, maybe? Because there is one word.
Franco, can you help us? Ci puoi far vedere l'ultima diapositiva?
There is one word that is probably crucial in the whole discussion, and it's true for scores, it's true for biomarkers. And the word, the last slide, and the word is actionable. So actually, that's the problem, because if you have a biomarker or if you have a score, it needs to be accurate, so it needs to be very well calibrated and able to discriminate what you want to. It needs to be available, so you have a biomarker that needs to be measured in your hospital. It should be cost effective. This is usually the problem also from the direction. And if you are in a position like mine or yours, you have to take also account of money, but this needs to be actionable. And that's the problem, because many scores we have, many biomarkers we have, they give you one number, but you cannot change the treatment, or you cannot change, the patient has a higher risk, but you cannot change the risk. So there are a lot of biomarkers, for example, for heart failure risk or for acute coronary syndrome risk, but they give you an information that you cannot change. And that's probably one of the problems in all the research that is done, that you get some information, but this information cannot translate into improved outcomes because they are not actionable. And we have a lot of, we discussed a lot in the heart failure community about that, because we have a lot of biomarkers that you can measure, but they have the treatment remains the same.
I thank you so much for this comment, because I think you said it beautifully. I failed to emphasize that enough in my talk. I completely with you. The actionable component of the score is what drives the difference between I don't care about the score because I don't need it in my practice, versus I need to calculate it because it will affect my decision making, the way I treat this patient. That's why I focus on these scores, because these are the few which are endorsed by the guidelines, which do have some actions connected to them. CHA2DS2-VASc, whether you give anticoagulation, yes, no. Synta score, how you treat this patient in terms of revascularization. Precise HBR, how long you should give antithrombotics. Then what the GRACE, I told you, the GRACE is extremely important. You don't want to do it, but you can delay an invasive procedure in a patient with very low GRACE, but perhaps not a very good idea to do another one. That is a very important. Prognosis per se is relevant until a certain point, because it's difficult to understand how you should use it. But the fact that the score gives you information how you should treat the patient, I think, is the future of precision medicine. And it's impossible to say that will not affect more and more our practice in the future.
Thank you very much. Brilliant as usual. Just have a provocative question concerning the component of the scores, because if you look at the several prognostic score in elderly, I would say in elderly patient, more or less all or 90% of the component are always the same: age, renal failure, hemoglobin, risk of bleeding, and which is at the end of the day the sense of the score, since you already dispose on all this information and you can integrate them very simply with a clinical reasoning. Because is a provocative question, because if you take the CHA2DS2-VASc and the ASBLED score, they just differentiate. They're very similar, apart one or two element. If you take the precise score, it's a very similar to other clinical score in other clinical setting, and all of them rely on the same clinical variables.
This is an excellent comment, and I think the answer comes from how the score has been generated and perhaps even more importantly, validated. So why Precise DPT is important? Because Precise DPT has been generated out of randomized control studies and has been prospectively validated in a dedicated randomized control study, which is interestingly enough what CHAT-VASc has never done. This validation of CHAT-VASc comes from retrospective application into prospective studies. What the future will be and how the score should be used should be informed by prospective randomized control studies testing treatment A versus B, trying to upfront nest into the design of the study scores which can risk profile the patient, deep phenotype the patients, which is what we did for Precise HBR. Precise DAPT or Precise HBR is unique because we have developed a study, randomized study, to prospective validate it. There are 45 bleeding risk scores apart from that one, but for the other one, nobody has ever done this prospective application. And that's what in the future the study should be. Why the syntax score is so important? Because the syntax score has been developed in whatever way, by consensus, by the way, and it has been applied from the get-go, from the study, in the syntax study, comparing PCI versus CBG in a prospective way. And at the end of the study, the score turned out to be a very important discriminator between PCI and CBG. That example, Precise HBR syntax score, should be reproduced every time a prospective randomized control study is performed. We test drug A versus B in heart failure. We should upfront try to deep phenotype the patient as much as possible to understand which patient benefit and which patient do not benefit from the treatment, which is something that we are interested with, but the companies don't want to do it because they want to get the full pie. And so that's why there is this tension between some academician, including myself, saying the score is the future of medicine, and the companies and the industry says, no, I want to get the entire pie of the heart failure patient, not just a small pie. And that tension should be resolved by prospectively phenotyping the patient into RCTs, because otherwise the score will never be actionable. Only if you prospectively do that in an RCT, you can know if and how much the score is actionable.
Maybe in addition, also, we know that many scores are used to help young physicians in the decision making. For example, the Wells score has been shown for the Wells score for pulmonary embolism is not superior to the clinical judgment of an experienced physician. So this has been shown and tested, but it's of course superior if you have a young physician in the first duty in the emergency department to make the first decisions. That for many basic algorithms are very helpful, in particular if you have unexperienced physicians.
Appearance is the best score. And what thinks the king of biomarkers just concerning score? What's your personal opinion? And then George.
Of course, I admire the work that Marco, that you have been doing, and I think several of the scores I think are really, really important. I still dare to challenge your strong passion for the gray score. I think it's useless because it's a score that combines elements that are not changeable. So, for example, you have a very high gray score if you're very, very old. You have a very high gray score if you have a very poor kidney function, if you are on dialysis. If I have a small end-STEMI, if I'm very old, I have a high gray score. There's no rationale, no biological rationale that early revascularization is better than doing it 6 hours later. In contrast, if you have a young patient who has substantial ST segment depression, it's not a yes-no thing like in the score, substantial ST segment depression, large area at risk, there's a strong biological rationale that this patient derives benefit from early revascularization. So therefore, I completely agree with the rationale and many of your examples, but I think the gray score is an example where, at least from my understanding, if we would use components that make more sense than the current ones. For example, a combination of ST segment, the extent of ST segment depression, and for example, the extent of heart failure, like NT-proBNP, or measuring the area at risk, possibly might do even better. I admire this work, but the gray score specifically, I think, is suboptimal by design.
I honestly completely agree with you with respect to the limitation of a gray score. That's what we have. And honestly, I think the gray score is a proxy of something, which is occlusion versus non-occlusion myocardial infarction. It's not perfect, but it's better than tossing the coin. It's better to say, no, don't look at the gray score. You can actually delay the procedure, because in the overall patient population, I don't see mortality. Of course, you do have a mortality benefit in patients with occlusion myocardial infarction, which poorly, but at least is some proxy to that detection early on. The score, to be a good score, it has to be completely updated and continuously updated. That is the challenge, because every time you make any change in that score, you need to have an external validation, perhaps not 1, but 10. But that is the future. If we would do that for all the scores, they will be better. CHA2DS2-VASc is a very poor score. At least it's something better than probably than nothing. But the problem of that score that has never been upgraded, never been optimized over time, which is basically misery. We should continue to improve them. And then, of course, we would have probably what you are suggesting, something which is more reasonable than just the first iteration of the score. I agree with that.
Altre domande? Giulio?
I liked a lot your comment on deep phenotyping. So I am also convinced about the lack of accuracy of several scores that we are using in routine practice are due to the fact that were developed on category of patients with the same level, but with multiple endophenotypes. And this is clearly shown by unsupervised machine learning algorithms in aortic stenosis, cardiomyopathies. And that's why also why we are very reluctant to use score to predict the risk of sudden death in different cardiomyopathies. So what do? We're now starting from a full understanding of the condition by genetic testing, and then mixing multi-parametric assessment or applying specific gene scores to the disease. So what's your opinion for the future? Do you think that also deep genotyping will fill the gap?
Absolutely. It's just a matter of time, and it's a matter of relying completely on a very complex multivariable modeling, because DNA, as you know, is huge amount of information. And the problem is what you do with that amount of information. You basically pick up a few polymorphism that you want to look into that. The future will be to integrate everything. And of course, there are some rare disease where genotyping per se, just looking at polymorphism, is driving already difference now, as you know, because you are an expert on that. We have many areas, for example, coronary artery disease, where we are not doing this because we do not know what to do with that information, but the future will be there. For example, we were discussing the ectasia phenotype of coronary artery disease, which is a completely different ball game. For sure, there is a polymorphism or multiple polymorphism connected to disease of the media of the vessel. For sure, there is, like aortic aneurysm, like aneurysm in general, but we do not know how to measure it and in which patient to measure it and how to treat that patient. If we add DNA of all patients at baseline in all our studies, prospectively, imposed by law, imposed by the SNF, imposed by BAG, whatever. But imagine that amount of information, how medicine would be progressed so quickly. That is the future. The future is whatever you do, you need to phenotype. And of course, if you have money, genotype as well. I would love to have genotyped all my patients, all my studies. But of course, that is extremely expensive. Not only because you need to analyze the data, but because the procedure of consenting patients is extremely more complicated. So you need to have dedicated budget for that. But that is the future. I have no doubt about that.
Was a project in Switzerland where they started to collect and try to genotypize just the volunteers, and they stopped after 100 volunteers just because of the money. It's extremely expensive.
Going back to your comment, you say in all your scores, you have simply the five, 6 variables which are repeated over and over again, because that's what we measure in studies. The score comes from the variables that you have in your database. The DNA, whatever, A, B, C, D, we never collected it routinely, so you don't have it available. And if you have it available in one data set, then you cannot validate the score externally, so you basically cannot include that coverage. That is the other limitation of the score, because you're right. There are no studies prospectively done purposely to generate a score. The score always comes from retrospective studies, means that the data set is never ideal for that purpose, which is another big limitation.
Okay. Marco, Christian, Fabio, thank you very much for your presentation. Thank you also for the audience for participating and also the participants connected online. Ringraziamo anche tutti gli sponsor che sostengono la formazione dei Pomeriggi del Cardiocentro e vi invitiamo, per chi è qui presente, a partecipare al rinfresco che è pronto di sopra, e vi ricordiamo che il prossimo appuntamento sarà giovedì 12 marzo con il titolo Targeting Inflammation and Regeneration, cosa deve sapere il clinico, e ci saranno come relatori Lucio Barile di Lugano e Giovanni Camici da Zurigo. A tutti una buona serata e al mese prossimo.